to the next session. And that session will be very interesting. It's on heart disease in women. Our moderator is Dr. Marielle Shearer-Crosby, MD, PhD, FACC. She comes to us from the University of Pennsylvania, where she is professor of medicine and director of the echocardiography lab. Dr. Shearer?
Thank you very much. I think this is going to be a very interesting session on heart disease in women. And without further ado, I'm going to introduce the first speaker, whom we've heard in a great talk yesterday, Martha Gulati, MD, Fellow of the American College of Cardiology, Fellow of the American Heart Association, Editor-in-Chief of CardioSmart, and Division Chief of Cardiology and Professor of Medicine at the College of Medicine in Phoenix, University of Arizona. And she's going to give the special lecture of heart disease in women. Dr. Gulati.
Well, thank you again for having me. Now I get to talk about my favorite topic, about women and heart disease, and I'm going to try to convince you, hopefully, that there is really a sex difference. So let's go back to the ancient Greeks, because the ancient Greeks really already at that point understood that men were different than women. And when they appointed a god of health, they actually were smart enough to also appoint a goddess of women's health who is known as Hygiena. So you know the staff with the snake that represents medicine? Well, Hygiena brought the snake. Women are always associated with the snake. But there is a lot of differences between men and women, and I'm going to give you a few examples. Here's one. This is how we see ourselves. And there's also differences between men and women about how we communicate. I have a weird sense of humor. I'm just going to admit that up front. When men say hi, apparently all they mean is hi. When women say hi, we mean so much more than hi. But let's get to the heart of the matter. And heart disease has been an issue since the 80s. We've been seeing in the United States more deaths in women compared with men. And it's only really in the last decade that we have made substantial decreases in mortality from cardiovascular disease. What's concerning, though, when you look at these survival curves for the United States, when you look at these death rates, due to cardiovascular disease, you can see in the last 3 years, though, we have started seeing an upsurge where we had been making good reductions in mortality in men, shown in blue, and women, shown in red. We now are seeing both of the death rates rising from cardiovascular disease. This may be the first generation that doesn't outlive its parents. And so that we're seeing it particularly in younger patients, which is really concerning us. And it really is now a trend after these 3 years of data. For women specifically, after they have a heart attack, they do the least well. And the question is always why? And Dr. Nanette Wanger, who's my mentor and friend, and really I'd consider her the mother of cardiovascular disease in women, said this in the late 90s. She said the medical community has really viewed women's health with a bikini approach, essentially discussing the breast and the reproductive system and almost ignoring the rest of a woman when we talk about women's health. She said that in the 90s, and more recently, I wrote an editorial saying that when are we going to move beyond the bikini? Because still, when you look at women's health, we still focus essentially on those same systems and not enough about the heart. In the United States, we have 1.2 million deaths in 2016, the last point of our statistics. And over 400,000 of the deaths in women are due to cardiovascular disease, making it the #1 killer of women. The second leading cause is chronic lung disease. The third leading cause, accounting for about 70,000 deaths, is lung cancer. And the fourth leading cause in the United States is breast cancer, accounting for about 40,000 deaths. Yet women often are very well aware of the risk of breast cancer and are very good about getting screening for that. For heart disease, if you take a room of women, usually they will tell you their heart has not been assessed, despite, again, just the numbers there show that it's the #1 killer. We could even talk about prevalence, and we mentioned that yesterday that over half of people in the United States are living with some form of heart disease, and it's 44.7% in women. And the prevalence of breast cancer is about 3.5 million in the United States, compared to the 60 million living with some form of cardiovascular disease. In Jamaica, the type of cardiovascular disease that is more prevalent in women tends to be stroke than coronary artery disease. Diabetes is obviously a huge issue in this country, and hypertension. I'll show you some of the statistics I could find. I actually couldn't find the death rate specifically by women for Jamaica by looking at a number of different sources. One of the reasons women have notoriously done poorly after cardiovascular disease is that we didn't really include them in a lot of our trials. And that is a major issue. And this cartoon sort of depicts it. It's kind of funny, except it's so true. We have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition. But medical research using women as subjects just never really occurred to anyone. And that, sadly, you even heard it today, that it would be more costly to do study by both sexes, and that's led to a lot of delays in us getting answers. Now, when we look at trials in cardiovascular disease and we look based on prevalence and if women are represented, we've made some headway in the last decade. In atrial fibrillation, we have gotten more women enrolled in trials where it really is proportional for the number of people living with the disease in the United States. Hypertension as well. Pulmonary hypertension as well. We've enrolled a fair number of women so that we can make statements related to women and cardiovascular disease for those conditions. But when you look at things like acute coronary syndrome, coronary artery syndrome, heart failure, the commonest diseases in men and in women, we still have an underrepresentation of women based on the prevalence of the disease in the population. Now, when I talk about sex differences, I'm not talking about gender. Sex, I'm talking about the biological differences, and I just want to be clear on that. But of course, when we're talking about women, we're talking a little bit about sex and a little bit about gender, because there is things about gender that make other parts of our lives different than compared to men. The lifestyle, access to care, access to insurance, poverty or wealth can be influenced by being a woman compared to a man, and where you live and how you live, of course. But biology, of course, there are differences between men and women just based on XX and XY. And remember, every cell has a sex. So there is sex differences. And I'm going to try to point out some of the things related to gender and some of the things related to sex. So let's just ask ourselves if we even treat women like we treat men. If we just followed the guidelines, would women get everything that men get? Well, sadly, the answer is no. If we look in the US at our data, the Get With the Guideline data, which the American Heart Association collects this data, it's voluntary, it comes from some of the best hospitals in the United States. Even there, we see differences between men and women. When we look at the adjusted odds ratio, the middle column here, if the odds ratio is greater than 1, it means women are more likely to have it. If it's less than 1, women are less likely to have it compared to men. And if it's equal to 1, it means women and men get it equally. Well, you don't see a lot of 1s, do you? Odds ratio of after having a myocardial infarction of getting aspirin or beta blocker within 24 hours, it's less likely if you're a woman compared to a man. In terms of revascularization, less likely if you're a woman compared to a man. Meeting the door-to-balloon time, the door-to-needle times, which are measures that we have that are there to help us see how quickly we're treating people, again, less likely if you're a woman compared to a man. The only thing women are better at doing compared to men is dying. And again, for ST elevation myocardial infarction, that's where it's most likely. This is older data, but we've looked at it more recently, and we continue to see the same trends. It's still worse to be a woman, and particularly in the United States, worse to be a Black woman. More likely to have bleeding, which has been a long-standing issue related to both our treatment of cardiovascular disease as well. So we do have a long ways still to go. If we would just follow guidelines, again, we could probably narrow this gap. We even use the Get With the Guidelines data to look at by age, because we are concerned about the youngest women being more likely to die. And here we stratified by under the age of 45 to compare to those over the age of 45 who had an ST elevation myocardial infarction. And in fact, there was really no difference, to be honest, except there's less women under the age of 45 having a heart attack, so the confidence interval is wider, but the same thing was found. It was just worse to be a woman. They were less likely to receive an ACE inhibitor or an ARB after a ST elevation myocardial infarction. You were less likely to receive lipid-lowering therapy. You were less likely to leave the hospital with controlled blood pressure. I don't know the reason for that. And again, the door to balloon time, door to needle time were less likely to be achieved in women compared to men. We've seen this in younger women too. So this is the VIRGO study that looked at women under the age of 55 compared to men under the age of 55 to see if there was a difference in treatment. And these are people who all had an ST elevation myocardial infarction. Now, when they saw that, the door to balloon time were to meet under 90 minutes, and they were achieving that in both men and women under the age of 55 if they did PCI in their hospital. But there was an 8-minute longer treatment for women compared to men. Now, if they were transferred from a hospital, there was a greater delay, and it was more than 30 minutes, and it didn't meet the standard of 120 minutes if you come from an outside hospital. Neither of these translated into higher mortality rates in the VIRGO trial, probably because these are some of our better hospitals as well, but at least it does answer a little bit that younger women are treated less aggressively, at least in a timely manner. We have data about rehospitalization too for younger women specifically compared to younger men. The rehospitalization after a myocardial infarction is much higher in younger women. It is also higher in older women, but the gap is not as great compared to the same age men. So on this slide, you can see the gray lines depict women, the black lines depict men, and the younger people are depicted by the solid lines. Now, there is approaches to try to improve this by having a system-based approach, and this is one study where they put in 4 steps. The blue bars are showing what happened before they put in this approach and showing that men did better, if it's above the line, than men. Men did better than women. But when they put in the 4-step approach, which was a standard checklist for passing off, especially in our emergency rooms that do work in shifts and people trade off, you've got to know what other people have done, that there was a handoff list, there was an immediate transfer to a cath lab if they didn't do cath in their own hospital, and also a radial approach, because women specifically tend to have less bleeding if we do a radial approach. You can see in the red bars, after these were implemented, where this checklist was all in place and they did follow the protocol, it still didn't become equal for women, but women did better. There was less of a gap between men and women. And actually, one thing they did see was that stroke was less when they did this in women compared to men. So there is reasons to think that, making a standard way of how we approach myocardial infarction could change it if we just could be a little less biased to whether it's male or whether it's female. And so I wrote this editorial last year saying that, some of the things that we need to do to improve outcomes after STEMI is really both educating women, educating healthcare providers, because there's still a lot of bias in how we treat women, as I will show you, and implementing these standard protocols, which will help. Artificial intelligence may help, and I'm going to show you an example of using AI in terms of reducing bias. And then also, of course, we need more research to understand these disparities in care. So the other question that I have for you today is whether women experience cardiovascular disease like men. And there's often this notion that women present atypically. And in fact, there's this syndrome called Yentl syndrome. It was coined by Bernadine Healy, the first woman to lead the National Institute of Health. And she noted these disparities between men and women, especially inclusion of women in trials. And so her point was by saying, there's a story of Yentl. Yentl, she was a woman. She wanted to study the Jewish rabbinical studies, the Talmud. In order to study them, she had to disguise herself as a man to be taken seriously. Her point of using the word Yentl in the story was that, do we as women have to disguise ourselves to be taken seriously? Do we have to present exactly like men in order for people to see that we have the same disease process? And there is an assumption, really, that that's the only way women will be taken seriously. Well, there was a notion that, the typical symptoms of angina may not be seen in women, and that women may present with more atypical symptoms. Regardless of whether you believe that or not, and I'm going to show you some data that will make it clear that I don't believe that, but women were less likely to have obstructive lesions. So they were, we don't always find the exact same pattern of cardiovascular disease in women as we've seen in men. And so sometimes that in the past was making people say that this is not, they don't have an obstructive lesion, this is not their heart. We now know that it can still be the heart without obstructive lesions. Women nonetheless report more angina. In numerous studies that has been shown they're far more symptomatic, whether or not they have obstructive lesions. But let's talk about how people present, because I do think that there is a notion that women present atypically. And the VIRGO study, that study of younger men and younger women, actually we had very limited data about that younger population. So they did ask about the symptoms, and they actually found that 90% of women and 90% of men actually did report chest pain or pressure or tightness or chest discomfort. The only thing that women did differently is they also reported 3 or more additional symptoms often. It was more likely in women that they would expand on that symptom. It wasn't just chest pain or chest pressure, but they might have had other symptoms. The problem is that it wasn't always seen. So, even patients themselves, there is some notion that heart disease isn't a problem for women, because when we asked them why, what was the reason that they didn't think this was their heart in VIRGO, men often thought it was a muscle issue, and women often thought it was anxiety. So initially that was the problem. When we asked them in this study what made you seek care, women were more likely to be worried about other health problems. Men did think, well, it could be my heart. Maybe I will go and get this checked out. As a result, women had greater delays in getting care. It was more likely for a woman to have more than a 6-hour delay in getting themselves in some way, shape, and form to the emergency room. Additionally, there was quite a big group of them, at least a third, that did seek out medical care before the myocardial infarction. And it was actually more likely that women would seek out care, but it was more likely that they were told it was not their heart. So it was, again, more frequent that a woman would be told it's not a heart condition compared to a man, and they would find other reasons. And again, remind you that all these people did go on to have an ST elevation myocardial infarction. Now, there was a recent study presented at ESC called the Hermes study. How appropriate, because we were in France when it was presented. And they showed the same, very similar findings in people that went on to have a cardiac cath, people that were reported to have angina. They found that 90% of men and 90% of women reported chest pain or shortness of breath symptoms. So there was truly... this is where they used artificial intelligence. They didn't care what the doctor heard. they had a machine recording everything that the patient described. And if the word chest pain was spoken or shortness of breath, it was recorded by artificial intelligence. And again, they did find that women were more likely to report other symptoms, but when they had an obstructive lesion, they still, 90% of them did report the chest pain as part of that problem. So artificial intelligence, they don't know if it's a woman or a man. They just hear what's being said. So maybe it's how we're listening to women. And I always say listen to women because they probably are telling you something. It is true that the more atypical symptoms were more likely to be seen or reported with women. But again, 90% who went on to have an obstructive lesion did have chest pain. So the other study that was also presented at ESC was the high stakes data, and those from the UK, and they again also looked at people reporting symptoms and those who went on to have a myocardial infarction and those who did not. And again, women were actually found to be more likely to have the typical symptoms as shown in these sort of target curves that you can see, the things in red. Above the line are the ones that are more likely to be associated with the typical symptoms, the pain in the chest, arm, jaw, dull, heavy, tight pressure, ache, squeezing, crushing, or gripping. And those were the things that they were asked about in addition to the atypical symptoms. But again, women were more likely to report the typical symptoms in those who had a myocardial infarction. There is other sex differences. I know today I don't have a lot of time to go in them, but we know for when people are witnessed to have cardiac arrest, it's less likely that women will get CPR. We know if you're less likely to get CPR or less likely to get defibrillated or you initiated, the recovery is certainly lower. There's a lot of reasons why people don't do CPR in addition to not knowing how to do CPR. Even those who know CPR are more likely to be scared to initiate it in a woman, mostly because they're worried about hurting a woman or exposing a woman, or what do they do about the breast? And so we are trying to change this. There's, we say that we don't have a mannequin, Annie doll, even though she has a woman's name, she doesn't look like a woman. And so maybe we need to be teaching on a womankin because that will help us actually make people more comfortable with treating women. Because, as we all know in this room, if you start CPR, you're more likely to save that person. So we have a lot of education to do to our population at large. So the other question I have for you is, do the guidelines actually apply to women? And I'm just going to briefly touch on this, not to get into microvascular disease too much, but from the 2012 stable ischemic heart disease guidelines, we were always looking for obstructive lesions. And in fact, that was the whole purpose. It's not that you have to read them all, the flow diagram, but it was basically who do we take to the cath lab to find disease? And that overt focus really misled us. And I remember being in medical school learning the other diagram there that is on the left, basically showing that the only way you could have an abnormal test or the only way you could even be symptomatic is if you have an obstructive lesion. And we know that that isn't true. So that's a diagram that needs to be thrown to the wayside. We know from many registry data and many studies, but this is the ACC NCDR cath PCI registry. When you compare women to men, you can see that women are less likely to have obstructive lesions compared to men, whether you're talking about stable ischemic heart disease on the top or acute coronary syndrome on the bottom. And yet, women have the worst outcomes, regardless of race. You can see stratified by both of those groups, women have worse outcomes. We showed some of the work that I did with the WISE study in my control cohort called the Women Take Heart population. We compared asymptomatic women to women that had evidence of ischemia but no obstructive lesions, and found that those people without obstructive lesions were more likely to go on and have adverse cardiovascular events. And this has now been shown again in other data. We don't know if the obstructive lesions, we're good at those. Cardiologists, especially the interventional cardiologists, they're just plumbers. They'll be mad at me for saying that. But they can open that up, and we know what to do with it. The problem is in those who have the small vessel disease, we can't see that in the cath lab necessarily. There's tests we can do to try to tease it out, but it makes it much harder. And perhaps this is one of the potential mechanistic differences between women, since we do see non-obstructive lesions more frequently in women. I won't go into ANOCA enough, but much at all, because it's a whole topic of itself. But ANOCA stands for ischemia with no obstructive coronary arteries, and there's a lot of gaps. We still don't know which test best to use. We don't know how to use all our imaging tools or in the cath lab, which one is the gold standard. We also don't know how to treat it entirely. And there's a lot of trials going on. So there's a lot of gaps for us to keep studying women, specifically because this tends to be a disease more often seen in women. I just think the most important thing is to recognize that, again, that the XX and XY is in every cell in the body, and there's all kinds of things that are affected by sex chromosomes that affect every organ in the body. The heart would be no different. And so it's important to take these considerations into your thoughts. So I'm just this might be the only thing you remember that women are not small men, and there's a lot we need to know about them. But I am a preventive cardiologist, so I'm going to just briefly touch on some risk factors that do affect women a little bit more differently than they do men. We know the traditional risk factors, but some of them disproportionately affect women, like diabetes. If you're a diabetic woman, the risk to your heart is much greater than a diabetic man. Even smoking, it's a greater risk to a woman who smokes than a man who smokes for the same number of cigarettes. Physical inactivity, some of my early work we did on fitness is that we showed that the effect of being less fit had greater cardiovascular consequences and mortality consequences. But there are things that are unique to women, like things that happen during pregnancy, things like inflammation, like lupus and rheumatoid arthritis, which are more commonly seen in women, that are states of inflammation that again, increase the risk of cardiovascular disease. I don't have to show any of you the risk factors in Jamaica, but for myself, I wanted to know what are the most common conditions here. And this is what is projected, the solid lines, but what the targets are, the global targets, of course, are lower. You can see that for women, obesity rates are higher, and as such, diabetes rates are much higher in women. Blood pressure still lower in women, but on the increase. And smoking, fortunately, looks like it's on a decrease for women, not so much for men. We put these things into our risk calculator. We can get a 10-year risk as well as a lifetime risk, which is very helpful. But aside from putting in woman versus man, there's really not much different here. So what are the things that are missing, or what should we use in addition to that risk calculator? Well, I think that there's a lot of things given to us at pregnancy. Pregnancy is nature's free stress test, essentially. It tells us a lot about women who might be at risk in their future, and these should be part of our history taking. Just in terms of the things that I like to ask about, the adverse pregnancy outcomes, things like preterm delivery, gestational diabetes, any type of hypertension during pregnancy, and fetal growth restrictions, small for gestational age. Those are the things that we have the strongest data to support. The other things, not as much. But 80% of women bear at least one child in their lifetime, and almost a third of them have one of those adverse pregnancy outcomes. So it should be part of our cardiovascular risk assessment. We have lots of great data. This is just one example from northern Finland because they can follow their population throughout their lifetime. These were all women that delivered in 1966, and any form of hypertension seemed to predict greater cardiovascular events, greater risk of stroke and myocardial infarction, but also greater risk of diabetes and chronic kidney disease as well. The Caliber study was released last year in the UK, and they showed, again, any type of hypertension or preeclampsia was a great predictor of stroke and cardiovascular events. Gestational diabetes as well. This is an elegant study from France looking at all pregnancies in 2007 to 2008 and following them for just 7 years. They're still quite young women, and those young women were more likely to have a stroke, myocardial infarction, or angina. So again, we're not talking that these are the people having their events in their 70s. We're talking that this is a predictor of things that can happen really in the next decade, and we're still saying they're quite young women. Preterm birth, we did this work and published it last year, showing again that preterm birth was having a baby before 37 weeks was a predictor of cardiovascular events, including stroke. And we propose this as a potential mechanistic way. It could be that risk factors are already present before people deliver, and there's something turned on during pregnancy, or there's something that is announced during pregnancy that puts them at risk later. And there's a lot of work looking at different things. The placenta may be important. Other markers of inflammation may be important. Hopefully it will help us be better able to protect our young women. I don't have enough time to go into about breast cancer and heart disease, and I know you heard a nice talk yesterday about cardio-oncology. I'd just say that, you know, there is a connection between heart disease and breast cancer. The link is quite close, including genetic things as well as cardiac risk factors, as well as the impact of the therapies that people get for breast cancer that can ultimately affect the heart. And they are a group of women that we should be addressing cardiovascular risk. So my approach for women is I do use the risk calculator to assess somebody's risk, but I need more. I need their family history. If they're high risk in America, we know veteran women, for example, are very high risk. If we have a coronary calcium, we'll actually calculate their MESA risk score. Then we use the sex-specific risk factors like the adverse pregnancy outcomes, as well as if they have a history of breast cancer. And then if they've gone through menopause, if they're on hormone replacement therapy, all of that matters. The female predominant conditions like lupus and rheumatoid arthritis would be the next piece of information I take in. And I feel like that's where the personalization comes in. We can't do genetics on everyone, nor will genetics change the outcomes right now for everyone. If we're not just asking about sex differences, the easiest thing to ask that treat women a little different than men in a good way, that will help us take better care of our women. So I hope that I have convinced you that, you know, that women have worse outcomes for myocardial infarction. And if we just treat according to the guidelines better for women, we can improve a woman's health. The younger women are at the greatest risk, and we still have a lot of work to do to tease out why. The symptoms for angina, I hope I'll convince you that they actually are more typical than we thought. I'm the chair of the chest pain guidelines for the American College of Cardiology and the American Heart Association. And if I have it my way, not that reviewers will tell me if I get it my way, but I hope to convince people to stop using that label because of the way it's been misused. Atypical, when my fellow comes and tells me, oh, they have atypical symptoms, they're telling me this isn't their heart. That is not what the definition of atypical is. It's supposed to be a less typical presentation than normal, but of heart disease in this particular case. I can't get into ANOCA or MINOCA today about the normal coronary arteries or the non-obstructive lesions, but I do think that it's important to be aware of that, and there's more data coming out about that. And I think the biggest thing we can do is assess cardiovascular risk in both our men and women and try to prevent heart disease before it happens, because as you all know, more than 80% of heart disease is preventable if we can just address the risk factors. So I'm going to leave you with the wise words of my husband. There's just so much more to understanding woman, and he put this out on Halloween to say that was him, that he was still waiting for me to get ready. So again, thank you for having me here.
So Dr. Gulati has to leave for her plane after this, so are there some questions for her?
This topic was so important to me because I see a lot of women who come in who have had untreated coronary disease for many years, and oftentimes it's because we're not expecting them to have it. And so when you're saying, okay, we need to look further, they'll tell you, oh, but my doctor said it wasn't my heart, so why you want to check? So it's really important also because I noticed you said the statistics in Jamaica showed that women were more likely to die from, or were more likely to die from CVA than coronary artery disease. And I wonder how much of it is the exact same thing in that a CVA is, the presentation is not missed. You know, if your face is drooping or if you have a hemiplegia, it's clearly a stroke. If you come in with your chest pain and we think, oh, it's just gas, or oh, you might be a little anxious, how many of our actual coronary artery disease, acute MI patients are we missing? And therefore, it's not factoring into our death rates from CVD. So
And it surprises me, to be honest, when I read the statistic that women are more likely to have a stroke, especially given the diabetes prevalence here.
Exactly.
It was actually
And the
surprising. I would have thought that, there would be more cardiovascular disease. And I'm certain that they're missing it. And I'm certain that, again, I will say that, we miss women because we focus on so many other issues and we're not educating. I think one of the things we have to do is also educate our population. If we educate our population that they're at risk, they will start asking you, but is my heart okay? I heard it's the #1 killer. In this particular society where there's lots of diabetes, lots of obesity, actually way more obesity. I was surprised to read the statistics for men versus women. On obesity, it's almost double in women, which is not what it is in the US. They're relatively speaking, just a little bit more in women. And the hypertension, for all those reasons, there must be heart disease, but they're dying from other things. Maybe they're living with issues, and then the stroke is just the final story, because these are mortality data. It isn't what people are necessarily living with. But I think there's a lot left for us to do, and I think in a society where there is so many risk factors, as there is in the United States, we have to be more proactive, because our healthcare dollars can only go so far, and we could be better at prevention and educating people the impact of these adverse health issues and trying to deal with that. I think that's probably the best way of using our dollars.
Quick question. There's Salim Yusuf's famous words: if a woman lives like a man, she'll die like a man. So heart disease in women is there. But I just wonder, is there any data anywhere that suggests that women with heart disease are better cared for by women cardiologists? Could there be an intersection between heart disease in women and women in cardiology?
Well, thank you for that question. I'd like to say that we should have more women cardiologists, of course. And I do think women in cardiology, not exclusively, because there's been many men at the front of the battle line with us. But I do think the focus in making sure research and inclusion of women in trials has largely happened because of some great women leaders. But to answer your question, there is actually data that treatment, when there's women involved in the care, that women do better. It mostly comes from emergency room data, so it's not specifically cardiologists. But in the emergency room, female physicians there is data. Again, there's lots of variables that they couldn't control for. But in that study that got a lot of press headlines, female physicians were taking better care of women and they were having equal outcomes. Now, when it was men and they were in an emergency room with more women, then the differences between the sexes mattered less. So it means that we must be sharing some knowledge with our colleagues. But specifically about cardiologists, I don't think we have that data.
I have a question. Excellent talk. But recently, within the last several years, in the software for EKG, when we have 12 lead, there is frequently this phrase, feminine pattern. you can see STT changes or inversion or depression anteriorly, and it's feminine pattern. And then, so you have a comment on that? If I see something like this in the men, I'm obviously very concerned. With the ladies, I treat them the same way. We are as aggressive as, because what we found that particularly in the younger ladies, if you miss something, it's a disaster. So we treat the same way everybody, although I must admit that in the old days there was this bias that the ladies, whatever, they outlive us and stuff. But with this EKG feminine pattern, I'm always very skeptical. I wouldn't, why is this feminine pattern? Do you have any comment?
So yeah, it's two different systems. I will say the Marquette system rarely gives that, whereas the Philips system, I've seen that in the report all the time, and I just cross it out. It's incorrect. And I think it's a difference between the two systems more than, I mean, we have to read our own EKGs and decide if these things are abnormal or normal. And, but I have seen the same thing. And hopefully, the problem with that, though, of course, is if an emergency room, someone who maybe isn't as equipped to read the EKG or, you know, as trained as a cardiologist, they might just believe that and decide it's not something they need to call about and not activate a cath lab. Hopefully, we're not missing STEMIs, but as you saw, even where we know that a STEMI has occurred, we are still treating women differently.
Just a question. Dr. Galati, thanks for your wonderful talk. And thanks for making mention of lupus and rheumatoid arthritis. I am one of the predominantly female rheumatologists. I'm not a cardiologist. And in our world, we've long, of course, recognized this cardiovascular risk, but our people have often stopped short of giving us precise guidelines to use on the front line. So I wondered what your practice was when the Framingham scores don't work and that you really feel like you're not quite sure if there should be a threshold or what the intensity should be if you use statin therapy.
Yeah, so that's a hard question because we just don't have, we have a lot of data that they have worse outcomes, but we don't know when we should be addressing them. What we do with our rheumatology colleagues is we have all those patients, every patient that has an inflammatory disorder, we actually have them sent to a common clinic where we assess the risk. We don't have any data. We know they have more inflammation. So what we try to look for is, do they have more risk factors? We know that it could be inflammation. It could be also a consequence of the medications they need that are to treat their diseases. And so we don't know which one is more important, but assessing cardiovascular risk, because they may have more diabetes, they do often have hypertension earlier, and assessing the risk at least is a starting point. And then you can decide about other testing, but I think having a joint pathway between rheumatology and cardiology, or whoever's your preventive team, I don't think it should fall on the rheumatologist, but if we can be partners in their patient's care, it really does make a difference. And I think we need more data, to your point of like, yeah, right now it isn't in the ASCVD risk score, and I don't know if it will be. But what should we do, the timing of it? Right now, we don't entirely know. We just know they're the higher risk group, so let's see them early and keep reassessing the risk.
Hey, Dr. Galati, thanks for that. I think you answered most of the questions. So in your slide that says my approach, if you had, say no rheumatoid, but if you had those risk factors that you looked at, are you advocating a much more, you have a young lady, 35 years old, who has some of those issues. Are you saying to see them more often? What do you do? Are you doing a calcium score? What are you saying about the follow-up?
So is the question, what would I?
What's the approach?
My approach?
Yeah. So you've taken a good physical, family history, rheumatoid, lupus. What are you advocating for follow-up?
Okay. So in general, I use the ASCVD risk score, Unless they have a coronary calcium score or unless I order one, then I use the MESA risk score, because the MESA, of course, involves the coronary calcium score as well. So if I have that information, or if I decide they need that information, then I will get it done and then recalculate their score. I use that every year when they come because risk factors change depending on how frequently. If I'm the one monitoring them, if it's, I'm often seeing people both for hypertension and for cholesterol. But I usually say if they're not going to address it, their primary care physician, then they need to come back at least once a year so that I can reassess it. If they're higher risk, we'll make decisions. We have to individualize it for the person in front of you about the different things that we would do. I, in general, don't necessarily repeat coronary calcium scores. The data on that isn't that strong. But I do it sometimes at a baseline, especially for the intermediate risk or the people that look low risk by their ASCVD risk calculator, but have a strong family history.
Yeah, but if I remember, the ASCVD risk factor wouldn't help with somebody, wasn't recommended for somebody that young.
It what?
Was not recommended for young people.
Oh, yeah, for the youngest
yeah.
people, okay. I'm sorry, I missed that. Yeah, so under the age of, under the age of 35, we don't have good data about risk score calculation. They don't end up in the calculator. So that for that population, for the pregnant women, we consider all of those things, those adverse pregnancy outcomes. We take a full pregnancy history. And that's basically how we decide if they're at high risk. What we also do for anyone who comes from our OB-GYN clinics is they get their blood pressure checked, but they also get their cholesterol checked, and then we make a determination of their risk. We don't use the risk calculator, we just kind of use the whole, is there any risk factors present, and work with them on their, that this is a lifetime issue. We feel we just don't have good data yet, but I do think that what we communicate to the young women who have just delivered their babies, in order for them to be there for their children, they need to be proactive, they need to be engaged. If there's dietary stuff, lifestyle stuff, and usually they're highly engaged if you get them at the right time. It's always a question. You can't talk to them right after they deliver because their only focus is on the baby. So we've been trying to tie it in to their 6-week visit because they're usually coming to their OB, and then we have them come and see us.
Okay. Thank you, Dr. Galati. We'll have to end questions right here. I'm so sorry. You will have an opportunity to ask some of these questions to the other people who are speaking in this topic.
So thank you very much. I am going to introduce with great pleasure the next speaker, and then I also have to take a plane, so thank you all for this wonderful meeting. So it's my pleasure to introduce my colleague, Dr. Victor Ferrari, who is a fellow of the ACC, of the SCMR, of the AHA, and of the American Society of Echo. He's a professor of medicine and radiology at the University of Pennsylvania, and he is also the chair of the Penn Cardiovascular Imaging Council and past chair of the Imaging Council of the ACC. And Dr. Ferrari is going to give you an update in cardiac imaging with a special attention in women.
Good morning. Thank you very much again for the nice introduction, Marielle. And without further ado, I think we'll focus on our topics today in imaging with women. I want to make an apology. First of all, I did not cover cardio-obstetrics today. There just wasn't enough time, but clearly that's an important topic. Mainly we focus on echo and also CMR with respect to potential myocarditis in these patients, but it's a topic I don't have time to talk about today. I'd also like to thank Jennifer Mirez for this slide, and given the theme of our conference for medicine and society, I want to remind everyone that we really need to integrate cultural competency and think about implicit perceptions when we're talking to our patients. And this concept of patient as partner, helping with decision making and also being an important part of the discussion with regard to care is critical. In general, we followed paternalistic approaches in the past, but we really want to follow patient-centered approaches as we move forward, and finally, the patient as partner approach. Interestingly, 80% of a population's well-being, if Rochelle is still here, that is the quality of life factors, social determinants of health, and actions in healthcare, and indeed also their happiness, account collectively for about 20% of society's well-being. And I think we have to also keep that in mind. A healthier population is a happier and more productive population in general. And I think everyone deserves to have that opportunity to be healthy and happy. There are some, with regard to updates in imaging in general, there are new landscapes and changing participants in the healthcare system. We're moving from a fee-for-service model in the States, at least that's what's been reported. It's a slower march than usual. And we're moving from fee-for-service to quality metrics. Obviously, that may hurt and is causing some pain and angst along the way. We're moving toward higher value rather than higher volume studies. So again, duplicative studies or the ability to order studies repetitively or in tandem, and stacking of studies, stacking of modalities is not going to be permitted. It's also obviously wasteful for resource-constrained countries. And we're moving beyond process measurement to outcomes and results. And obviously, this is where the rubber hits the road. Dr. Galati has introduced a number of these topics, so I'll move quickly through this. But just in terms of imaging and men versus women, in general, women have smaller hearts than men. That means that chest geometry and breast size may complicate optimal imaging with echo, but this is usually not a problem. Generally, we can move beyond those constraints. However, thinner myocardial walls create challenges for the assessment of non-transmural ischemia. I showed you yesterday an MRI perfusion study demonstrating subendocardial ischemia. That's more challenging with PET or with SPECT if the wall is even thinner in terms of detecting true ischemia. And also, smaller infarcts may be missed on SPECT or PET with a thinner wall and lower signal intensities with nuclear imaging approaches. And in general, women have smaller coronaries than men, which complicates the accurate assessment of the distal coronary arteries and on CT, and also the FFR CT calculations. So all of these things need to be kept in mind, in front of mind for treatment of patients with coronary disease. Now, depending on the chest configuration and breast size, women can absorb up to 30% greater radiation than men. And therefore, when possible, non-ionizing radiation tests are preferred. And this is especially important in younger women whose lifetime radiation exposure may be relevant regarding future cancer risks. I'll also direct you to two papers that we wrote last year regarding the impact of radiation on patients and also operators in cath labs or in EP labs. And studies are getting longer and more complex lately, and the operators need to be more cognizant of this as well, Stefan. In terms of quantitative cardiac imaging, this is where some differences are important to recognize and may not be in front of mind for us when we're performing these studies. Echo relies on geometric assumptions as to cardiac shape, and it assumes a bullet-shaped left ventricle. And while that's fine for normal hearts, generally we don't treat patients with heart disease that have normal hearts or study this in great detail from a research standpoint. This introduces errors in the measurements in diseased hearts of mass and volume and ejection fraction. And off-axis imaging leads to errors in calculation. This is particularly important in deformed hearts, such as those post-MI that have an aneurysm. Now, tomographic imaging, such as MR and CT, eliminates these assumptions and the obliquity errors, and since an entire 3D volume is acquired. And while 3D echo is available for imaging, for volume and ejection fractions, it's not quite ready for prime time, unfortunately, except for certain TE applications. But for transthoracic echo, it really hasn't hit its mark just yet. Now, Dr. Galati talked about symptoms in women. I'm not going to belabor this, but we always have to remember that symptoms can be atypical in women, and it limits, there are frequently limitations in patients and women exercising on treadmills to hit their target heart rates. Obviously, advancing age, orthopedic problems, and conditioning issues can reduce the sensitivity and specificity of stress testing. And we already know that there are low sensitivities for women because of EKG abnormalities that are different from men, reducing the specificity for exercise EKG down to about 60%. Stress echo has only about an 80% specificity for coronary disease, and stress spec slightly higher at 81%. In terms of disease prevalence, there is a much greater incidence of non-obstructive coronary disease in women, and therefore a higher risk of plaque rupture in these 20 to 30% lesions. So while angina may not be the most prevalent symptom, acute MIs are in greater frequency with these smaller lesions. Now, we obviously need to listen to our female patients more carefully. I want to read these statements that I think are really important, and I think they really encapsulate the problem. Even when accounting for sex differences in risk factor prevalence, a smaller body size, higher bleeding risk, and other factors, women have decidedly worse outcomes after coronary revascularization, particularly in the near term. So just going in and fixing the plumbing isn't going to be the answer. Also, the lack of symptom-driven care for women that have demonstrable ischemia is a major contributor to their worsening ischemic heart disease outcomes. INOCA and MINOCA are really important in reducing women's favorable outcomes with ischemic heart disease. And interestingly, 1 year after the index evaluation of patients, of women with symptoms, nearly 40% of symptomatic patients have persistent or worsening symptoms. So clearly our current approaches leave large gaps in the understanding of coronary disease in women. Now, are gender differences important in stable ischemic heart disease? They certainly are. If we look at this data from the extent of coronary artery disease by coronary CTA, we can see that women on the left, while they may have less incidence of non-obstructive coronary disease than men in general, if you look at the outcomes and the survival for three-vessel disease or left main disease, it's dramatically lower. And I think this has to do with the fact that women escape detection early in their course and often have more severe disease or more critical disease after a time duration. And here's a good example of that. We have a QCA stenosis of only about 36% on the left-hand image. That would be obviously non-severe, non-critical disease. But look at the coronary CTA that is associated with that lesion. It's complex. There is calcium there. There is soft plaque. This is a lesion that could potentially rupture and is at risk for disease. We also need better tools at assessing which lesion is most vulnerable and which is the most active, and whether we're shutting off inflammation satisfactorily, not just a serum CRP, but maybe even a local imaging tool to show that we're really reducing that residual risk that statins and anti-inflammatory properties of ACE inhibitors provide. To bring you to the PROMISE trial, this was a study that looked at coronary CTA versus functional imaging. And these were about 10,000 patients that had suspected CAD and intermediate coronary disease risk. The composite primary endpoint used was death, MI, unstable angina, hospitalization, or a major procedural complication. The study had 53% women, and 88% had chest pain or dyspnea on exertion. There were also some secondary endpoints, which I won't go into at the moment, but interestingly, there was no difference in the outcome between coronary CTA approach for diagnosis versus functional testing. And the CCTA group had a greater mean but a lower median radiation exposure, and that was more reflective of the site variation rather than true risk. That is the site where these studies were performed in the across the geography of the trial. And interestingly, more patients underwent revascularization, both PCI and CABG, but that wasn't actually a true trial endpoint. If we look at the outcomes of patients, the anatomical testing and the functional testing showed a comparable outcomes. And this also relates to the following slide, which shows that there is increasing mortality with an increasing number of abnormally perfused regions in women and men by rubidium PET. But here there are definitely differences in gender differences between men and women with regard to outcomes, but interesting, the trends are the same. That is, with more abnormal regions of disease, there are more events. I wanted to remind you that these small infarctions that are detectable with coronary MRI, with cardiac MR, excuse me, that are the footprint of a subclinical coronary event are important and have an important step on outcomes. In a smaller or thinner wall, smaller heart and thinner wall, we're not going to see these abnormalities on nuclear imaging, and therefore CMR will help pick this up. In a society that has a high prevalence of diabetes, missing subacute infarctions and coronary events can be critical in reducing outcomes. Now, just as an introduction, there are some misconceptions about cardiac MR. It's been criticized as taking too long, can't be performed in ill patients, lacks exercise performance data, there are motion artifacts, and it's limited in terms of prognosis by smaller studies. I just want to show you this image, which is a planar axial MRI using a technique called compressed sensing. That is an ultra-fast MRI technique that is now standard on CMR imaging machines. And what this does is provide nearly isotropic resolution. Now, that means that the pixel size, that is those picture elements that make up every voxel or vox element within the image, are nearly the same size. That is, these are 1 millimeter by 1 millimeter by 1.25 millimeters. The benefit of CT angiography is that it is isotropic. They have sub-millimeter resolution, so 0.6 by 0.6 by 0.6. So you can twist and reconstruct the image any way you'd like and see the image at the same resolution in each view. With cardiac MRI, we're getting closer to this isotropic resolution. This is the closest we've ever been to assessing coronary arteries themselves with CMR, and the resolution for myocardial detection and structural detection is absolutely outstanding. So this is a new era in cardiac MRI. Now, with respect to lacking functional information, that is how far a patient can go and how many METs they can perform, there is now available a stress device that is a treadmill that is MR compatible, can go into the room, and patients can exercise at the bedside using these ultra-fast imaging techniques. We're able to have the patient lie on the table and slip into the scanner, and we can image the heart at heart rate and at target heart rate, and have that image information about, have that prognostic information about their level of exercise performance. Now, I want to present a case to you, and this is of interest to our rheumatologist friend who asked the question earlier. This is a 37-year-old who presents with visual changes, chest pain, and tachycardia, a heart rate to the 120s and 130s. And she was diagnosed with cerebral lupus. The question was, does she have lupus myocarditis because of this inappropriate tachycardia? And very interestingly, on the MRI scan in the upper two panels, on the left-hand side is her baseline image, and on the right-hand side is after treatment. We can see that her myocardial edema, that is inflammation as detected by T2 mapping with MRI, showed a significantly elevated signal of edema within the myocardium. That is inflammation, active and acute inflammation in the myocardium. And interestingly, her stress perfusion MRI study shown in the lower panel shows diffuse subendocardial hypoperfusion. That is, if you look at that dark ring along the internal border, that is the endocardial border, just adjacent to the bright blood pool, you can see that there is subendocardial ischemia. This cannot be well detected with echo, and with SPECT, this would be eluded. It would not be detected with SPECT. PET does a better job than SPECT of detecting it, but sometimes PET can miss mild subendocardial edema, subendocardial hypoperfusion, such as this. Interestingly, after treatment, in the right-hand panels, her myocardial T2 signal came down. That is less edema and resolved. This is in the normal range now. And look at her stress perfusion MRI scan. It's now normal. So she had an acute inflammatory episode with lots of microvascular dysfunction at the time of the inflammation that has resolved with treatment. So detecting these abnormalities instead of just saying this patient just is anxious and has a tachycardia is critically important to her care and also her prognosis. So our overall paradigm for imaging considerations for women in coronary disease can follow this type of rubric. And I'll recommend this paper by Lauren Baldessari and Leslie Shaw as a guidepost for you. Looking at the non-obstructive high-risk plaque in women is critically important. Understanding the extent of disease, its configuration, and whether a woman is at risk or not for coronary artery disease is extremely important. And so identifying those abnormalities, either with coronary calcium scores or likely coronary CT angio in women that are symptomatic and have a risk profile that would require it and that would support it is important. In the middle, looking at the PET scanning, these are studies of the functional abnormalities, that is microvascular dysfunction, where nuclear imaging and CMR have value. And then finally, recognizing scar, the presence of real scar, or unrecognized myocardial infarction, subacute clinical scar is a big factor in detecting disease. I also don't have time to go into MINOCA or INOCA in great detail, except to say that myocardial infarction with non-obstructive coronary artery disease, as well as ischemia with non-obstructive coronary disease, is an important problem in women. And the causes of myocardial infarction with non-obstructive disease, such as coronary plaques or erosions, spontaneous coronary thrombosis or embolism, or missed obstructive coronary disease, and we frequently see that now that we have better coronary CTA and myocardial assessment with CMR. Are important. Obviously, myocarditis, including giant cell myocarditis, which is particularly virulent and damaging to the myocardium, Takotsubo and other hypertrophic cardiomyopathies can be detected and are important. And on the INOCA side, vasospasm and then microvascular dysfunction are two important diagnoses that we can't miss in women. I'll direct you to this paper by Dr. Galati also, Improving Outcomes for Women in STEMI, listening more carefully at the beginning, including more women in trials, and recognizing that we should have more standardized protocols are among the ways to improve outcomes with STEMI. This is a demonstration of a large number of patients with, who have undergone stress CMR, and this demonstrates the value in a group of over 11,000 patients who had stress CMR in terms of the positive and negative predictive value for stress CMR. The event rate with a negative stress test, that is, what's the value of a negative stress test? It's a event rate of less than 1% per year. That is either death, MI, or a combination of both. Whereas a positive stress CMR has an event rate, an annual event rate of nearly 3% for either death or MI, or almost 5% for the combined infarction, MACE. So it's an excellent test for assessing prognosis, either positive or negative. Now, I'll introduce you to two trials that were performed recently. The CE Mark trial, which shows that CMR in blue had a greater area under the curve or greater predictive capacity for coronary disease than than SPECT imaging, and that was in any type of any severity of coronary disease, 1, 2, or 3 vessel disease. And the MR Inform trial, which compared FFR-directed therapy to stress perfusion CMR in terms of accuracy for prediction of coronary disease and also outcome. And we see that the curves are overlapping for CMR versus FFR. So CMR is as good as FFR for detecting ischemia and coronary disease in patients. So, Dr. Galati mentioned the WISE trial, which demonstrated that the spectrum of coronary disease extends beyond the epicardium to the microvascular disease, as well as endocardial dysfunction. There's a lower epicardial coronary disease burden in women, but more angina and poorer prognoses. Interestingly, in the PROMISE trial, which was stable ischemic heart disease, women were identified as lower risk, quote unquote, despite having comparable risk factors, and had 2 to 3 times the events with more angina in 1 year post-MI. And future algorithms, I believe, must include functional, anatomical, and physiologic assessments of coronary disease, both endothelial and the microvasculature. And CMR, I believe, is the ideal test for ischemic heart disease in women, and that's my opinion. Coronary calcium scores in women. There was a discussion earlier, a question earlier about risk factors and what do you do with women, young women that might have symptoms. Unfortunately, coronary calcium scores are not have questionable utility in women between 45 and 64. You can see the percentiles by race. Top white, second Chinese, third black, and fourth Hispanic. Across the races and ethnicities, there is a low incidence of coronary calcium positivity in younger women. So that may mean that coronary CT angio is more informative because it can detect non-calcified plaque as well as small calcifications that might elude coronary calcium scores, and also give us an idea of these 20 to 30% lesions that are mostly fatal. I don't have time to go into great detail about FFR-CT, but it's been proposed as a measure of degree of ischemia. Unfortunately, it's 4 times the cost of the coronary CT angio, and it is unproven in terms of predicting value in patients with stable ischemic heart disease, which is where it's used most frequently. Interestingly, a core lab demonstrated that it increased that is coronary FFR-CT cost the trial in the advanced registry about $6.8 million. It also increased the incidence of PCI and CABG, that is increased total revascularizations by 14%. And the estimated cost for the additional revascularizations were $16.5 million. So therefore, adding the cost of the FFRCT of nearly $7 million to the $16.5 million increased the cost of care to these patients by almost $23 million. So the question is, does FFRCT really get us to goal? I'm going to hold my opinion on that. Just some data that helps, that CMR helps distinguish multivessel from microvascular disease and reducing costs while increasing efficacy. A strategy of using cardiac MRI stress testing before going to catheterization versus catheterization itself was effective across all countries here, Germany, the UK, Switzerland, and the US, in inpatients and outpatients in terms of any strategy followed for detection of suspected coronary artery disease. And interestingly, a stress CMR prior to cath saved one hospital $14,000, nearly $15,000 of hospital costs per life year. $15,000 per year. And these lower costs at follow-up, which is about 1 year follow-up in these patients, suggested sustained cost effectiveness of the CMR guided strategy. So now, in terms of other value that imaging can give us with regard to differences in gender, and interestingly, across ethnicities, the MESA trial has been a way to mine that type of data from a group of asymptomatic patients. And interestingly, we've seen differences in men and women in terms of right ventricular function, as well as a number of other parameters that the MESA trial has used. I also want to mention cardio-oncology in imaging. The use of echo and particularly strain has helped us better understand the effects of non-ischemic myopathies and chemo-induced myopathies in patients and help detect subclinical abnormalities before they become important drops in ejection fraction. So either 2D or 3D strain can be helpful, and also CMR provides utility in cardio-oncology with respect to identifying myocarditis and myocardial edema, tagging for strain, and also parameters looking at diffuse fibrosis or focal fibrosis. Dr. Scherer-Crosby has been very active in looking at the cardiac effects of CAR T cell therapy. That is the new chimeric antigen T cell receptor therapies, which are the breakthrough therapies for oncology now and are being used across many different diseases. We'll see more data about this, but in some preliminary data, there have been cardiac events in patients with T cell therapy, just like there have been with therapy for breast CA. So we really need to be cognizant of cardiac effects of chemotherapeutic agents and cellular and molecular therapies, and particularly gene therapies down the road as we treat disease in patients. I promised you this slide of the young woman who had progressive scar when I presented verbally yesterday. Here's the data. If we look at the top image, this is a subacute study, a patient about 1 week after presentation with chest pain and positive troponins and acute myocarditis. But we can see that 2 months later, 15 months later with symptoms, she had progressive scar, that is the bright signal within the apex, septum, and lateral wall of the myocardium. And this occurred in the setting of normal ejection fraction. So she still had a normal ejection fraction, but progressive scarring in these areas. At 2 years later, after her initial presentation, she developed frequent non-sustained VTs, had 2 episodes of syncope, but still with a normal EF, and on EPS had an easily inducible monomorphic and polymorphic VT. A conference was held among those subspecialists. She did not meet requirements for a ICD by low ejection fraction, but it was implanted based on risk, and within 2 months, she had multiple shocks for VT at a heart rate of 250 beats per minute. That was life-saving. So risk stratification with scar particularly in women, for ICD therapies and potential risk stratification for arrhythmias is on the horizon. Great. I don't have time to talk about the use of PET and MR as combined image or fusion imaging, but obviously detecting inflammation and then looking for structural abnormalities can be helpful, particularly as we try to diagnose sarcoid more accurately and more consistently. So finally, I'd just like to say, and thank you for your patience, that women's heart disease is much different than men's. Listen to women more deeply. They're trying to tell you something vital, and they're much more complex than men, as we know. Non-obstructive CAD is fatal. Be sure to diagnose it, and CCTA may be our way to do that. And prognostic data for microvascular disease with PET is real and has an impact, and therefore is vital to exclude. And then echo strain and CMR strain as well will have an impact on understanding of cardiomyopathies, all types of cardiomyopathies. And this deep phenotyping of looking for early evidence of missed ischemic heart disease is critical for female diabetic patients, and we must be aware of those abnormalities. I will also mention that the ischemia trial, recent ischemia trial, which evaluated patients with moderate to severe ischemia, conservative versus invasive therapies, had a sub-analysis. This is the most talked about trial that doesn't have a paper out yet, so we can't drill down further into the data, but there was reportedly no difference between men and women with moderate to severe ischemia in terms of outcomes, conservative versus invasive therapies. We'll need to see that data to really believe it, but just as a foreshadowing for what's to come. Thank you again.
Thank you, Dr. Ferrari. To continue with our topic of heart disease in women, I'd like to invite to the stage Dr. Elizabeth Ofili. Dr. Ofili is a well-regarded, highly respected physician. She's professor of medicine, senior associate dean of clinical and translational research at Morehouse School of Medicine. She's the chief medical officer at Morehouse Choice Accountable Care Organization, member of the National Academy of Medicine, and chair-elect of the Association of Black Cardiologists. She'll come and expand our fund of knowledge on women in heart disease. Thank you.
Good afternoon, everyone. So I was just sitting in the audience there and just marveling at how everybody's just been amazingly attentive, and of course everybody's a scholar, so you'd think they'd be doing their own thing, but people are really paying attention. And that's credit to both of you organizers. I want to thank you for the opportunity. And also, I actually kind of want to borrow this stage. It looks like the Oscars. I see. Great, that's why it's called Masters. But so my topic, and I do thank my colleagues who spoke earlier, made it a little bit easier for me to navigate, but I'm focused specifically on heart failure in women. And where do I point this to? Yeah, I know, but where do I point it? So these are my disclosures, and they won't really have an impact, except I will in the final slide when I discuss the ABC Cardiovascular Registry. I will talk a little bit about our technology that's being used in that NIH-funded project. So I want to be able to just share with you, specific to heart failure, some of the sex differences, and specifically focus on some attributable risk, and hope that we will together agree on the rationale for sex-specific preventive approaches for both heart failure with reduced ejection fraction, as well as heart failure with preserved ejection fraction. and then utilize the most recent clinical evidence to inform treatment decisions and management of heart failure in African Americans. Of course, given where I spend quite a bit of my time, I also hope we will come away from these discussions with an urgency and really understanding from the standpoint of where healthcare is going, as you heard from earlier speakers, the notion that we cannot continue to talk about disparities and the gap and just share data and not have enough to help people understand what happens in the context of a number of social determinants that we alluded to earlier. And so I was very fortunate actually with this topic because while I do speak on heart failure, overall I tend to spend quite a bit more time in the ethnic and racial disparities with some effort with women. But fortunately, Jack just did a special session in March of last year focused on heart failure in women. So that actually served to provide some of the information that I was able to pull together. Basically, both doctors, O'Connor and Lilienfeld, talked specifically about how the reason for this special issue was really trying to pull together some of the data that's been out there, but also more speaking to why we need to focus or refocus, I should say, on some of the research efforts, as well as highlight what's working. So in terms of prevalence of heart failure in women across the lifespan, what you see here probably mirrors some aspects of cardiovascular disease. But interestingly, and perhaps not surprisingly, when you look at women after the age of, once they're in their 50s, there's a dramatic rise in the prevalence of both heart failure with reduced ejection fraction, so-called HFrEF, and preserved ejection fraction, so-called HFpEF. And just so I don't keep stumbling on my words, from going on forward, I will refer to it as HFrEF and HFpEF. That's how we talk about it in the heart failure arena, as those of you who do this know. But again, coming back to the reality here, when you look at prevalence of risk factors for heart failure in men and women, similar to what we saw for cardiovascular disease, but you notice here that the red bars, which represent women, and the blue bars representing men, when you look at hypertension, women have a greater prevalence of those risk factors, and perhaps representing the older age of women when they have heart failure, and also the disproportionate impact on influence of minorities. And obesity is also important for both men and women, as is diabetes, and of course, coronary artery disease. I think population attributable risk from my standpoint is quite instructive. And what you see here for both HFpEF and HFrEF in women, hypertension really dwarfs everything else. And of course, obesity, quite important in terms of women relative to men. And you see their diabetes equally important for both HFrEF and HFpEF. I should mention here, I misspoke, obesity is most important for HFpEF versus reduced ejection fraction. So not uncommonly, as we see in clinical practice, when patients come in with congestive heart failure, sometimes you find a lot of hypertensive heart disease, a lot of obesity, and not necessarily some of the obstructive coronary artery disease. And all of that morphology, I think, is still not clearly well understood, and opportunity for additional exploratory research. So this is one of the questions, one of the papers in the special issue asked the question, is cardiac diastolic dysfunction as part of the postmenopausal syndrome? And of course, we recognize that withdrawal of estrogen leads to quite a bit of the cardiovascular disparities we see in women because of the older age and lack of estrogen. And this really feeds back into, from the microvascular standpoint, increased systemic vascular resistance, to pulmonary vascular resistance, to, of course, what's going on from the cardiac standpoint and muscle. However, with all of these pathophysiology and the physiologic drivers, I should say, we all remember that the Women's Heart Initiative clearly showed that you can't just replace estrogen and have a positive outcome from a standpoint of heart disease in women. So while this is important from the standpoint of etiology and perhaps how we explore new therapy, estrogen from a therapeutic standpoint is absolutely never recommended at this point. The preserved ejection fraction heart failure was also studied from the standpoint of exercise, hemodynamics. And interestingly, there was a very good paper that used echocardiogram as well as integrated aspects of invasive monitoring. And not surprisingly, there was, of course, the data that sort of underscored, I should say, what was shown with the estrogen mechanistic data. And that is the fact that the systemic vascular resistance problem, the pulmonary vascular resistance problem, and the myocardial issues in terms of left ventricular hypertrophy and fibrosis seem to play a role in the dynamics of reduced exercise capacity in women with heart failure and preserved ejection fraction. So this is a very old data from 1999 when I first got to Grady Hospital, really asking question about why do we have so much heart failure in this predominantly African-American patient population. And my colleague, Dr. Nanette Wenger, at that time pointed out that hypertension is a big driver, and I had to really go look at the data. And in these 1,200 individuals that were hospitalized over a period of 12 months, as you can see there, she was right. Hypertension was almost universal in terms of comorbidity for hospitalization in heart failure. The other risks you see, perhaps understandable, given this patient population: left ventricular hypertrophy, uncontrolled hypertension in 2/3, CAD in half, and diabetes in 40%. Now, one of the interesting things about this data, this database, as we evaluated it, is almost 60% of the patients are women. One of the gender differences that we noted actually was that the presence of diabetes and left ventricular wall motion abnormality was actually an important, significant driver of hospitalization for women. So this is sort of now kind of historic, but I think there are still things that come back in terms of where we're at today, as you'll see when we talk about heart failure. I just want to, before we leave the subject of some of these female-specific etiologies, I want to talk a little bit about peripartum cardiomyopathy. I know you had a discussion on cardiomyopathy. I wasn't here, so I don't know if this was mentioned, and if it was, please pardon me for repeating. But specific to women, peripartum cardiomyopathy remains an important problem, and part of what we've continued to observe is there are issues around sort of some difference in how women present. Some women will have complete recovery after the baby is born, whereas others will go on to have significant heart failure and some needing transplant. There was a major session at the last Heart Failure Society of America, and Dr. Dennis McNamara, who does quite a bit of this work in looking at new potential drug targets, made an important description, presentation, but we still came up with that. We don't know enough. We're still studying this, and they have a significant study that would hopefully provide us with some answers. And I know this is probably too small to see from the back, but the bottom line here is, as I mentioned, there is a difference in how women present, so a lot of the treatment has to be individualized. You treat them for heart failure when they're acute, but at the end of the day, a number of this is about preventive approaches and preventive strategies for these women, and some women may never have another pregnancy based on how they presented initially. So I just want to bring up a couple of other things that are sort of more modern in terms of what's going on with care and more serious illnesses, such as individuals that have more advanced heart failure and needing to go on to transplant, what's happening with their treatments, such as LVAD therapeutic approaches or left ventricular assist devices, as well as their effort with transplant. So what this is showing, though, is when you look at these women who are either getting these assist devices or awaiting transplant, there continues to be significant morbidity, particularly when you look at how women are affected versus men. So again, women are in red and men in blue. And so here, the blue bars versus the red bars, I should say. So here we're looking at cerebrovascular disease, multi-system organ failure, cardiovascular disease, infections, pulmonary hemorrhages, and renal failure. All of these issues have women actually having more significant morbidity compared to men. And then when you look at who's actually getting durable LVAD at the time of transplant while they're waiting, as you can see, there's a reversal here, so women are disadvantaged. They're not getting some of these. And of course, it could be because they're very sick at the time, given some of these comorbidities, or it could be because people are just not referring early enough. Regardless, this is an important problem from the standpoint of advanced heart failure. So just to mention some of the discussion, to add to some of the earlier discussion around cancer therapy, what we do know, and again, this was one of the papers that I was pleased to see in the JACC special issue, is, and because I see this in my practice, that more and more women are coming in with heart failure based on, and they have had cancer therapy, particularly the adjuvant chemotherapy for estrogen receptor sensitive cancers. And the bottom line here is, as you can see, when women get chemotherapy, there's already an increased incidence of heart failure, but having the adjuvant therapy dramatically increases the risk, and that's the most, the lighter line to the left versus chemotherapy, which is the darker blue curve. And one of the recommendations that's coming out of this, at least from the American Society of Clinical Oncology, is to get echocardiogram within a year of completing chemotherapy. But I think you have to really look at what the women are presenting with. I have had women come to my practice, they have just completed their chemotherapy, it's only been 6 months, and they're symptomatic with shortness of breath, so we have to be sensitive to go in and do the echocardiogram a little bit earlier, and stress testing sometimes needed in these individuals. I think the guidelines will eventually catch up. But this is an important data that was just, again, presented because it clearly showed that 18 months after the diagnosis of breast cancer and completing therapy, women have a twofold higher risk of developing heart failure. But I should quickly point out here that it is still a relatively low prevalence, but we need to pay attention to it. So this was an editorial that was presented in the JACC special issue. I should say actually following the JACC special issue, was not in the same issue. And Noreen Walsh talks a lot about women with heart disease. So I think this is an extension of that thinking, but bears recognition from a standpoint of heart failure. Women, according to this editorial, and I happen to believe that, are unheard, untreated, and unstudied, or if you prefer, maybe underheard, undertreated, and understudied, if you want to be less dramatic. The bottom line is we have work to do. One of the papers that really caught my attention, and this is especially in the context of some of our new therapeutic approaches, and I'll touch upon that in a minute. But when this was an analysis that's being shown here that actually took multiple studies over 4 decades and looked at how those studies reported adverse drug reaction. And what you notice here is there's a reporting of adverse drug reaction across the decades, and this is so from earlier decades on the left to the later decades on the right. The light gray, the darker gray is the overall reporting, but when you look at studies that separated out adverse reactions in women, as you can see, very low rates, 12%, 7%, 6%. So you don't have enough data within these studies to actually define or to report adverse events in these studies. So what does this mean for therapies that are approved and we're out there using them? This sort of summarizes what the problem is. We know that women present differently from men, particularly more common prevalence of heart failure with preserved ejection fraction versus men. We also know that there is increased susceptibility to adverse reactions and perhaps influencing adherence to treatment. So we need to separate out when clinical trials are done to actually understand not just what the NIH really with the Office of Women's Health, people were tasked with defining and analyzing data to make sure we're understanding outcomes, but also adverse events. And unless we're focusing on this, we won't know how this is playing out, particularly for women and minorities. I don't know how many of you saw the recent publication. It was actually a post-analysis that looked at electronic medical records and saw that the recently approved drug based on the Paradigm Heart Failure trial, Entresto, or sacubitril valsartan, works well for heart failure in whites, but does not seem to have any effect in blacks. Now, this is deja vu all over again for those of us who remember the arguments with ACE inhibitors and blacks and not being as effective. And so this brings us to how far we've come with heart failure, but how much little we know, especially when we're talking about women and minorities. So the TOPCAT information, the TOPCAT secondary analysis that's shown here, also reference the fact that we know the overall TOPCAT data. This is for those who may not remember this. This was looking at heart failure with preserved ejection fraction and whether spironolactone was effective, because we know spironolactone is effective in reduced ejection fraction, very effective. Unfortunately, TOPCAT was not significant in terms of the role of spironolactone, but this secondary analysis actually found that there was significant interaction between sex and the treatment arm, because there was reduction in all-cause mortality in women. But we will never know because there was not enough in the overall trial to say, is this something we should be doing differently in women? Again, this speaks to why we should enroll more women, but also be willing to do the analysis based on the number of women in the database. Overall, all is not lost. We have enough information to treat women well and treat them appropriately, but keeping in mind that we need to gather more data. And this is just a summary slide that's saying, at the end of the day, there's value in some of our current therapeutic approaches, and we know beta blockers work well. We know absolutely controlling hypertension is important. I think, and controlling all risk factors are important in preventing both heart failure with preserved ejection improving heart failure with preserved ejection fraction, as well as heart failure with reduced ejection fraction. And I just want to share again, it's more advanced, so patients who are being hospitalized, but this is good news. Credit to my colleague, Dr. Aneko Anwanyi, who's Chief of Cardiology at Morehouse and co-director of the Grady Heart Failure Program, actually director of the Grady Heart Failure Program and co-director of the Cardiovascular Service. But this has been going on for some time, really looking at reducing readmissions, and you can understand why hospitals want to focus on this because of the cost of care. And the data has actually been quite persistent now in terms of patients that are being readmitted, much lower numbers, and the program that was put in place in terms of consultations, as you can see, pre and post consultations, almost a 50% reduction in patients being readmitted. And this has been tracking this over time from 2018 to last year. So that's the good news. This is the not so good news. In terms of disparities for heart failure with African Americans with heart failure. And we know why this is it. You heard some of this today. I'm sure you heard some of this as well in the earlier sessions yesterday. But when it comes to actually treating these patients, it seems that we're still falling short. I just give you this example. This is a 58-year-old woman who presents for follow-up, she's been hospitalized with heart failure 6 months earlier and was sent home on these drugs. And for those of you who've heard me speak before, you know I'm immediately going to say something is missing here, and I'll just keep my powder dry for a second, as one of my mentors used to say. But so she's on valsartan, carvedilol, because she's allergic to enalapril, furosemide, and I think this was maybe a few years ago, but probably after Paradigm, someone would have probably had her on sacubitril as well, because a number of my colleagues are definitely doing quite a bit of that. But based on the evidence that's out there, there's something that's missing in this patient's care. Who knows what that is, since you guys haven't been privy to my soapbox? Can anybody tell me what's missing in the care? Except for Dr. Hutchinson and Dr. Shigati, you can't say anything. What's missing? I'm not hearing anything. So I'll help you guys out. Fixed-dose combination isosabide dinitrate and hydralazine is missing, also known as Bidil. We remember this study because the Association of Black Cardiologists was very much involved with this. This was published back in 2004. It has this kind of data, and the placebo is everybody else who was getting ACE inhibitors and beta blockers and spironolactone, et cetera. And yet this treatment worked. And 15 years later, less than 10% of blacks who qualify are getting this therapy. So I should say, too, that almost 50% of the participants were women, so this is also relevant to women. So this patient, if she had a voice, would probably ask some questions. And I've had patients in my practice who's been around different hospitals in Atlanta, have not been put on the appropriate therapy that's been proven for blacks, and have come to see me, and I've tried to correct the wrong, but our practice, we're only one practice. What's happening around the nation, to me, is a travesty in terms of the appropriate care of African American patients. I just want to share this as we come to a close here. As part of the data, the heart failure, JACC heart failure special issue, I was pleased to see a patient's voice. This is a woman who's living with heart failure. And as you can see, she's been, well, you can't see because you didn't read the paper, but I'll tell you. She's been working with a number of women and community groups to raise awareness about heart failure and need to participate in clinical trials. Well, she had some comments about, we don't prioritize clinical trials enough because sometimes when we have information on the website and a patient would call, somebody will say, what now? What are you looking for? Because most of the practices, most of the clinical practices are not necessarily doing clinical trials, and the shops that are doing clinical trials at academic institutions are just doing clinical trials. So I think part of the transformation that I'm going to close with is why we need to integrate clinical trials with care. So this woman, for example, said, we do clinical trials because we want to know about timely treatment. When the new studies are coming out, we want to be a part of that. She believes that it helps with understanding what's going on with care. If you can imagine when you're diagnosed with a condition, you want to look and see what's out there that's new and novel. She states that as a patient, considerate treatment should not just be during the clinical trial, but before and afterwards. In other words, communicating the data with the participants and sharing with them and seeing how are they doing and how can you get that therapy to them if the treatment worked. We did that with the African American heart failure trial. Everybody in placebo was eligible to receive the treatment once we got the data that Bidil was effective. All right, unlike my previous speaker, I don't have President Barack Obama telling people that the injection will hurt. I have President Barack Obama giving a press conference following the final State of the Union address. Many of you may not have recalled that, but I'm very much into precision medicine, so I remembered that he gave a press conference following the 2015 State of the Union, and the whole excitement was around precision medicine. And he was particularly interested about the opportunity to get new medical breakthroughs. I should say here that leading up to this, obviously, is a lot of effort that has been done through that administration through the Office of National Coordination on aspects of data science that folks like me who do research are starting to reap the benefits of that. But also importantly, as a result of this, there is a whole effort to recruit 1 million diverse Americans in the program that's called All of Us. I want to give credit here to Priscilla Pemo at Morehouse. She's part of the Southeast Enrolling Center, and they are, along with University of Miami, Florida Gainesville, and Emory, are doing a good job of bringing in diverse patients. But this is all over the country, and I'm particularly interested and excited about this because I think it's starting to turn the tables a little bit and put some emphasis on what the patient wants and what the patient needs. So the patients begin to ask us questions, and when they participate with us, we have to take their point of view more significantly into consideration. So I'm going to close with this. The ABC Cardiovascular Registry happens to be one of those projects that have had a long time coming. I have two past ABC leaders here, Dr. Barbara Hutchinson, as well as Dr. Felix Chagade. Both of them, as leaders, were interested in this, and I have to say they put their practice where their mouth is, or they put their practice where they don't have big mouths, so I was hesitating to use that analogy. But the reason ABC Registry is important is because I've talked about all the things that we've really mentioned over the years about disparities in equity, and yet registries have been done, and they still have majority patients, few African Americans. We don't have enough emphasis on social determinants of health. So one of the opportunities we have, especially since, at least in the United States now, most practices have electronic medical records, is to begin to look at transforming how we do registries and clinical trials, so we're not having these sunk costs in a warehouse that becomes obsolete, or in a data warehouse that becomes obsolete because treatments have changed. It would be good if we can just go in and query the data that's in practice and have information that can support a clinical study, or better still, an information that can influence the quality of care as care is being delivered. And this is what we're doing with the registry. We just got some funding from NIH to implement a technique called FHIR, F-H-I-R. This is where you can actually go in and interrogate the electronic medical record in real time, pull out data, ask questions, and have the information stored in the cloud, so it's not as expensive for some of our participating practices. I believe this effort to democratize research, democratize data science, and importantly, democratize who has access to the data, because the cost and barriers to entry have to be significantly reduced if we're to make any impact on all of these conversations about health disparities and health equity. New treatments that may or may not work because they weren't studied, and we're forced to use them because that's what's been approved. And I thank you for your attention. So, are we going to have anybody else join, or I just stand here? I just stand, okay. I thought we were going to sit on the fancy couch, but that's okay if we're not.
Actually, the fancy couches are waiting for Drs. Knopp, Dr. Spencer, and, well, it's just you and and Dr. Ferrari. So if you all have any questions, particularly as it applies to women in medicine, women in heart failure, women, and how we present with coronary artery disease, it's really important. And this is also something that leads into our lunchtime talks. obviously, we're running a little bit late because, of course, you know, island people time. You all came a little late, and we wanted a full audience for our speakers. But it's particularly important for us to talk about how women present and how we treat them differently sometimes and underestimate the impact of disease because we're not seeing adequate treatment in our populations, and we're not seeing enough attention paid to what the actual impact of heart disease is in our population in general, but particularly as it applies also to women. So if anybody has questions,
Yes,
we are
Dr.
anxious.
Dr. Elizabeth, I really feel supported in the sense that you mentioned the ridiculous amount of Black people included in the paradigm trial. It was about 215 persons, and most of them African Americans. That motivates us here in Jamaica to do some observation in our population. So, because we were really in the same matter of, we have no any proof that the RNA therapy is effective and safe in our population. They mention angioedema, they mention improving in the ejection fraction. So we start some observation. Our cohort is still growing. However, we have definitely more consistent data now. We have a heart failure with ejection fraction treated with RNA therapy, and for some reason, I don't know if the microvascular illness is most important here, because non-ischemic cardiomyopathy is the most prevalent, but apparently some vasodilator effects of the RNA is making a good effect because we are seeing reverse remodeling in a spectacular way. The data is not published, but probably we have one comment. And second, Dr. Ferrari, Takotsubo syndrome is very important. The link in Takotsubo is cardiac dysfunction and stress probably, and adrenergic drive. So one comment in the images.
Okay, so Dr. Afili, he's asking about RNA and that we're seeing really good results here. So I'll let you take it first.
Hello? Oh, yeah. So thank you for that. And I think that I also hear that. And one of the challenges we have in medicine is we treat one patient at a time, and we make some conclusions. Of course, we want patients to get better. And I've heard of reverse remodeling. But the challenge I have is the data is not large enough. And I honestly don't know what else those patients are not being treated with. So I think I applaud you for using the sacubitril valsartan. But I would say, at least based on the patients that I see, and I've said this in major meetings, I think the impact of hypertension on the microvasculature, the fact that we have demonstrated on multiple data and research that there is some level of nitric oxide deficiency in patients who have predominant hypertension, diabetes, not necessarily just about Blacks. So I am, oh, the lights are changing.
It's the
Woo! Somebody is trying to trip me up here. So, I mean, again, I think it's commendable that you're doing that, but I want to just continue to say, we should look at therapies that have worked in the patient population that we're seeing, because the social determinants of health could have an impact. If you didn't recruit those people, and they were just people from Europe, which was the predominance of the data, how do you know it's going to work for your practice, right? So that's just my challenge. And we still have to treat people, so I think we should treat people, but I think the bigger picture, in the not too long distances, we've got to have the numbers and have these unique registries that would allow us to answer the question. Sorry.
Okay. And then it was you, Dr. Ferrari.
I wanted to be clear about your question or comment about Takasubo to be sure I answer it properly.
What is the best images test to assess Takotsubo syndrome?
I see. Great. Thank you for the question. I think ECHO provides the best value and also the quickest screening for the procedure. Now, interestingly, Joao Lima and his colleagues published a very nice study in the New England Journal of Medicine. I'll refer you to that to look at some of the mechanisms underlying Takasubo cardiomyopathy. It's really exciting that we have two types of cardiomyopathies that are reversible: Takasubo and also, in general, the cancer. The adjunctive cancer therapies causing brief and usually reversible cardiomyopathies. Understanding the mechanisms of those changes could help us understand longer-term problems with cardiomyopathies and potentially provide clues or targets for preventing or even treating cardiomyopathies in general. It's a very complex issue, obviously. I'm not trying to oversimplify it, but just to say we have two near-term types of cardiomyopathies that are reversible and we can study more clearly. CMR may provide some additional insights into that above and beyond just imaging the structure and function.
I wonder if peripartum cardiomyopathy feeds into that as well, because sometimes after pregnancy, they become completely better, the ejection fraction goes up, and some of them, when they have another baby, get pregnant again, the heart failure sets in. So, I mean, it sort of fits in that, some reversibility.
You're absolutely right. And Zoltan Rani, who was one of the co-authors of the article you showed on peripartum cardiomyopathy at our center, has been doing some very nice work with at the basic science level and translating that to humans. Imaging, again, in that regard. Echo is the predominant modality, but CMR also provides some insights if it's not reversible, to determine how much scar is present.
Right. Are there any other questions?
Yeah. This question is, I think, directed mostly at Dr. Spencer. I currently work at a Mayo Clinic. I'm also a member of the U.S. Preventive Services Task Force, and I say that because I believe prevention is better than cure. But also, very clearly, there is a resource issue in these communities where the needs are really great. And yet the access to the expertise and the resources aren't there for us to deliver the care that's needed. So I guess the question, Heart Institute is really well known for telemedicine. What I didn't hear from your presentation was the role of telemedicine, or telemedicine could play in the delivery of more specialized care. Instead of people coming into your operating rooms to provide assistance for surgeries, is there a role, for instance, in telemedicine in delivering those surgical procedures that are needed, even for CABG or other procedures?
That's a difficult question. Telemedicine in assisting surgical procedures is probably not something that is required in our setting. It's not that the persons operating do not have the expertise to do the operations, which is what I understand from telemedicine helping the operative process. It's lack of certain materials that is our problem. And as you know, the cost of these materials is quite significant. And to try to address the cost, one has to determine who will provide the funds for the cost of this material. Our health service highly dependent on contributions from the health ministry. But unfortunately, the funds, approximately 70% of the funds that are provided by the Ministry of Health go towards salaries and rather than basic renewal of equipment and so on. I don't know if that has answered your.
Okay, I'll go. Yeah, two questions, one for Dr. Philly and one for Dr. Ferrari. I'll go with Dr. Philly first. I like the slide you showed about the role of estrogen in inhibiting the oxidative stress and thereby impairing or delaying apoptosis, And we had a great lecture this morning from Dr. Anderson about the role of reactive oxygen species, and I know a question came up whether there was a sex difference in some of these things, and I think that probably shed some illumination on that. I don't know if that's something Dr. Anderson may comment on later as well, along with your answer to the question about what specifically how estrogen plays this role. I think we may need to have more information because we know just giving women estrogen alone does not solve the problem. And the second question for Dr. Ferrari is the role of, the best imaging modality for women. As you know, when we go to fixed imaging using CT, which is actually being pushed by a lot of health systems in the United States now, CT-FFR, and I'm kind of quite impressed that you showed that the cost is significantly higher. But in addition, we have a lot of incidentomas as well, a lot of breast lesions that will be picked up, maybe sometimes, and of course, a lot of lung lesions that, just leads to more and more testing. Whether this actually long-term results in clinically advantageous situation for the patients needs to be defined. But I don't know if you have any data to guide us about all the sort of things that we see in the process. Sometimes we feel very good that we saw something. I just walked up a patient that had triple vessel disease, just came in because his brother died, but then they saw a lung scar, went to operate the scar, they took out probably a big chunk of the lung, the lesion was benign, and just worry about, what are some of the consequences of, we need to define it a bit better.
So to respond to the question, the comment and the question about the potential, definitely the potential role of estrogen and opportunity to continue to explore that. So as a non-basic scientist, when I look at some of those pathways, I'm clearly understanding that there are many things that obviously affect the oxidative process and how that influences the vasculature and inflammation. And estrogen definitely plays a role, and the problem though is when you begin to look at a therapeutic approach, most people don't just take estrogen, right? And even with the contraceptives, when you give estrogens and low-dose estrogen, there's still a danger that's related to other aspects of estrogen, whether it's on the blood pressure or on the thrombotic risk. So I think the totality, when you go beyond just the isolated physiology and the cellular activity, is what happens in the real world when women who are older, who may have incidental and undiscovered and untreated coronary artery disease, and they're treated. And I think that's part of why we had this big problem with the Women's Health Initiative. Is there a way to further refine that and think about maybe getting the benefits of estrogen without the risk? I suspect people are still experimenting with that. And right now, there are people doing that in the non-mainstream market, the homeopathic people and people who are doing natural medicine. But the problem is the data is not there. Just like we all swore about the benefit of estrogens because women felt better, but didn't know all of these downstream effects and that people were dying from heart disease. So it's not a good answer to your question, but I think your question probably raises a lot more questions about how we should design these studies to understand better how we can be applicable to real people. So, I don't know, Dr. Anderson, he threw a thing at you. You want to, did you want to comment?
I mean, I would just say that this is a huge unanswered question. I pointed out, sort of my struggling for a good word, but shame over not addressing it. We do see sex-dependent differences in lots of animal models. We have really rarely followed any of them just because it doubles the number of studies that we have to do, and we don't have funding to do it. But I think it's a core issue that we have to work together as more early and late translational scientists to advocate for the kind of structure and funding to make this happen.
Thank you for your terrific question, because it gets to the core of our medicine and society theme. And that is, what is the individual, or how do we balance the individual benefit of testing versus the population benefit of testing? And also, how much of our country's resources do we put into preventative care or diagnostic imaging? In general, women develop coronary artery disease, symptomatic coronary artery disease, about 10 years later than men because of the presumed estrogen benefit, or at least sex hormone benefits. And therefore, they are generally later in the course of their disease when detected. But the early detection that may be possible with coronary CTA, particularly the diagnosis and detection of non-calcified plaques. And I think that's in that window of the 45 to 64-year-old females, that's where the coronary calcium score is not helpful, but coronary CT angio will pick up very small calcifications that plain calcium scanning don't, but also the non-calcified plaques predominantly. Fortunately, it's rare, but for those women that have that disorder, they are at greater risk of having an acute MI because of the remodeling of the fibrous cap of the plaque and rupture of those plaques. What we need, and to get to your question, what we need, I think, are better population-based, gender-based, and ethnic-based studies to know when the role of cardiac imaging, particularly coronary CTA, is cost-effective, and where the tipping point is for balancing society's benefits and the individual's needs to be treated. What would be great is if we had a simple blood test, something cheap and accurate, that could detect maybe an active plaque or remodeling of the fibrous plaque within a lesion that would be rapidly deployable to many different parts of the country. We're not there yet, but I think we should move our sights toward simpler non-invasive testing and less expensive non-invasive testing than we have now. But we can't treat patients with tomorrow's technology today at the moment. So.
Okay. We have time for one more question, and
just a quick question. It's not really a question, it's just some clarification for Dr. Feely. I just wondered whether, if I get you correctly, you're urging caution with the use of sacubitril valsartan in African populations. Felix may have neglected to tell you that he actually presented our data at the European Society of Cardiology's Heart Failure Summit in Greece a few months ago. And we have very impressive reverse remodeling data. Secondly, that the cost of sacubitril valsartan is a fraction of what it is in the United States. What I wonder is the possibility of sort of maybe unintentionally withholding sacubitril valsartan from African American populations, particularly those who are uninsured. You're depriving patients of a potential benefit. Not that it's harmful, but its question is, could that be, part of the? You have a study with low numbers in terms of representation of African Americans, and should that be the basis for consideration, or should we have data that drives decision-making in our own local environment?
So I think that I'll tell you what I do in my practice, but I think you should do what works for your practice. I think at the end of the day, when there's insufficient data, people have to act based on clearly what's available and what will be helpful to the patient. Drugs are approved, and so I don't think I would withhold at all. When you look at the data, though, from the FDA review, there was more significant, almost an 8-fold rate of angioedema among black patients versus non-black. Huh? So that's good. And I think to the extent that you're continuing to follow the patients, I would not withhold sacubitril valsartan from a heart failure patient, especially if you have access at a low cost. Based on the AHEF trial, though, in my practice, I first use fixed-dose combination acesulfame dinitrate and hydralazine. I know that sometimes people talk about the number of pills, the pill burden, but in my experience, you can get away with 2 pills a day and people get better, and we also have seen reverse remodeling. But I think all of these drugs, perhaps because there's some influence on nitric oxide, because certainly sacubitril valsartan has some of that effect as well. So I don't mean to confuse or miscommunicate. I think patients should be treated based on the best information that's available, as well as the economic impact of care. But we should not make an assumption that patients cannot afford a certain treatment if it's the best treatment that's based on the data. That's what I would quarrel with if we assume that something won't work. But it sounds like you're the opposite. You've gone for the diamond and you figured out a way to get it to the patients and treat them, and you have not shown side effects. So keep gathering that data, because it will take thousands and thousands of patients for us to really know long term. This gives me an opportunity to point something out. To the extent that we're all looking to artificial intelligence to help us as we gather more data, there still needs to be caution, because recently there was a whole brouhaha with United Health Group, because we found that some of the data they were using was actually adversely impacting black patients. I think all of this speaks to sometimes when you don't have adequate data, sometimes your conclusion may not be correct. I'm not saying that's what's going on here. I want to be very clear. You follow the patient. How many patients do you have in that group that you're talking about?
Probably under 100. But,
Under 100.
Compared to a few hundred in Paradigm.
Yeah, under 100. So keep tracking and keep following. And quite frankly, if you are not in the context of a registry, at least if it's in our case in the US, sometimes patients may have an adverse event. They go to one hospital. If you're not tracking them, you may not know what happened. So I encourage you to have, as best you can, since you have this number, grow it into a registry.
Okay, excellent. That ties into what my belief is, in that just because you think somebody can't afford to pay doesn't mean that you shouldn't give the best advice about care. And obviously the best advice is not always cheap, but we will try to do the best we can. So we thank you all for your contribution, and I'm sure as the conference goes on, we will have questions that we will try to get answered as well. Okay, we are going to have a brief break. Oh yes, please, give a hand to all our speakers. Especially the one who thinks our stage is Oscar-worthy. Yes. So lunch is being served in the back. Some of you have already been served. I'd like to ask our speakers, you all can sit and lunch will be brought to you. In the interest of time, we're going to do that. And the others have already been enjoying to go into our break room and you can have lunch. You can come back to your seats once you've collected your lunch. We are having a very important Lunch and Learn series. This Lunch and Learn series is sponsored by ResMed, and I think it, like I said, it flows nicely into our talks and our focus on women in heart disease and just about women in general. And so you will not want to miss acclaimed author Melanie Schwab, who's going to come and give us a little balance from straight medicine, but talk about issues that affect women in a little bit of affairs of the heart. Subsequent to that, we will hear from ResMed on adaptive ventilation. So thank you for your attention.
I'll return your microphone.